Hello and welcome to part 4 of male reproductive pathology. Here I'm just going to go through a quick summary of some of the male genital disorders. If you've had urology or so forth, you might have already discussed a lot of these disorders and you can skim through most of this. If this material is new for you, then you should spend maybe a little bit more time understanding some of the most important conditions we need to be on the lookout for in our male patients. So we'll start with the disorders of the scrotum and the groin. The first would be undescended testes or cryptorchidism, also known as hidden testes. We discussed this in the anatomy and physiology section, so I'm just going to kind of review some of this. And this is really the absence of one or both testes in the scrotum. Basically that's failure of the descent of the testes during embryonic development or fetal development through the inguinal canal into the scrotum. And most cases are unilateral, involving only one testis. And usually this process begins in the 7th month of fetal development where the testes need to descend. It's the most common birth defect of the male genital tract. It occurs in about 3% of full-term and 30% of premature infant boys. In about 80% of cases, the testes actually descend within the first year of life, so no treatment is needed then. And the overall incidence is about 1%. They can become trapped anywhere along the path of descent of the testes, from just below the kidney all the way to the inguinal ring. They're most often felt in the inguinal canal, so that would be kind of a high scrotal or inguinal testis. And they can also be ectopic, where they can wander from the normal path of descent, and that would need to be detected via ultrasound. There's something known as testicular dysgenesis syndrome, and that is involving cryptorchidism with hypospadias, that would be an abnormal urethra opening, we'll talk about that here in a moment, testicular cancer, and poor semen quality. So that's testicular dysgenesis syndrome. Complications of cryptorchidism would be infertility, because again the testes have to be kept cooler to allow proper sperm development. Now, importantly, steroidal genesis will still occur, especially in the unilateral cryptorchidism. The other testis produces normal testosterone and whatnot. Bilateral cases, there might be some effect on steroidal genesis. There is an increased risk of testicular germ cell tumors and increased risk of testicular torsion and inguinal hernias. And then in adults, there can be obviously psychological issues with having an undescended testis. So the treatment is usually, again, in the first year of life, 80% of cases self-resolve. So most are going to descend. Some may actually reascend. That's going to be pretty rare. Hormone therapy might actually help them descend, especially human chorionic gonadotropin injections. That's between 5 and 50% effective, and GnRH agonists can also help them descend. But typically, cases after a year, or especially 18 months, are going to need surgery, and that's orchiopexy done by a pediatric surgeon. So that's cryptorchidism. The other main kind of genital scrotal disorder to be aware of here will be inguinal hernias, and that's the protrusion of the bowel into the inguinal canal or scrotum. And that's can occur in males or females, although it's going to be more common in males. And there are two types of this. One is the direct hernias, and that's the less common type, and that's where the abdominal contents protrude medial to the inferior epigastric vessels. So they're going to pass through a weak point in the abdominal wall, an area called the Hesselbach triangle. So with direct hernias, we're going to get some protrusion of the intestinal contents there into the upper areas. An indirect hernia is where the abdominal contents protrude through the deep inguinal ring, and usually that's due to failure embryonically of the processus vaginalis. It doesn't close properly. So this can cause the bowel to go all the way down into the scrotal sac, and that can cause a bulging in the scrotum. That's going to be in about 65% of cases you're going to see symptoms. So not all cases will be symptomatic, but that's going to be bulging, and it's going to be rarely painful unless the intestinal loop twists upon itself and becomes incarcerated. And that's where we start to see real problems, obviously. So the incarceration strangulation, you start to see severe pain and tenderness in that area, possible bowel infarction, and that can result in sepsis and can be fatal. So we're always on the lookout with hernias, whether or not they need to be treated and whether or not there's any incarceration. So the most common approach for asymptomatic, more mild hernias is really watch and wait. So it's that's the kind of typical approach. But with any evidence of strangulation, that's going to require surgery, and there are different techniques, either open approaches or laparoscopic approaches for that. So that's going to be pretty noticeable on scrotal exam. This would be a mass in the scrotum, for example, that does not transilluminate. Transillumination is when you put a light behind the scrotum. If you can see the light through the, shine through the scrotum, that's transilluminating. If you don't see the light, it's not transilluminating. These would obviously, if there's a big area of intestine in the scrotal sac, it's not going to transilluminate. You can also, of course, if you're putting the finger up the inguinal canal and having the patient valsalva, you might feel a loop of the intestine come down and reach your finger. So these would be some of the typical findings on physical exam. Now with scrotal swelling, let's look at some of the painless causes here first that you need to be aware of. So the most common is probably a varicocele, and that's an abnormal enlargement of the pinniform plexus, the venous plexus in the scrotum. It's the most common cause of scrotal enlargement in adults, and it's most common on the left side. It occurs in about 20% of all men, and it's most frequent earlier in life between 13 and 30 years of age. And we think it's due to almost the same conditions that cause varicose veins, to venous valve incompetence or compression. That could rarely be the result of cancer, compressing the venous plexus there. And that's going to result in higher testicular temperature because the blood is not draining out appropriately, and that would result in testicular atrophy and potential infertility. So this is a very common cause, remember, of male infertility, up to 40% of cases. The exam will reveal palpation, a non-tender, feels like a bag of worms along the spermatic cord. Very classic finding there. So again, with scrotal exam, there'll be the bag of worm kind of non-tender palpable mass. It does not transilluminate, and that would be our next step, if we suspect that, would be to send for a Doppler ultrasound, and that would allow us to visualize that. The treatment, which may improve fertility, would involve surgery, and there's a varicolectomy or embolization. So you can remove some of those veins or basically cauterize or inject something to essentially prevent the blood flow from going into some of those veins, and that would cause them to atrophy, and that's done by interventional radiologist. So that's varicoceles. The next kind of scrotal disorder to be familiar with would be a testicular hydrocele, also causes a painless swelling, and this is accumulation of serous fluid around the testicle, again usually painless, and that's going to cause significant swelling, and that might even cause atrophy over time of the testes due to compression. There can be congenital causes. Again, this has to do with congenitally the processus vaginalis, which becomes the tunica vaginalis, we went over this in the anatomy and physiology section, remains connected with the peritoneal cavity. So you can have what's called a communicating hydrocele, where the peritoneal fluid actually flows all the way down into that space, and that enlarges it. You can also have a non-communicating, where just the tissue layers in the tunica vaginalis separate and they become filled with fluid, and you can have it higher up here as well in the spermatic cord. So there's different types of hydrocele, so that would be congenital. It can also be acquired from orchitis, from infection, trauma, hernia, torsion, or a tumor. And then you can have a hematocele, where blood also finds its way into the serous fluid. So those are the different types of hydrocele. The assessment here would be, again, scrotal exam, a usually painless enlargement of the scrotum that transilluminates. So you will be able to see the light shine through the scrotum when it's shined on the backside. And then we usually, at that point, will send a patient for an ultrasound to rule out any tumors. The treatment, if it happens early in life, it usually resolves spontaneously. But if it reoccurs, and especially in adult patients, they might need surgery. Unfortunately, aspiration, where you just pull the fluid out, has a very high rate of recurrence. So usually that reoccurs. Sclerotherapy is where they inject an agent to try to block that flow. So that's another option there. So these are all cases we just refer to the urologist. Now, that said, I did, on a patient with a hydrocele, adult patient, use a combination of diuretic herbs. I'd have no idea if that's what resolved it, but his hydrocele, which was quite large, about the size of a grapefruit, resolved within about 2 months of using that herbal therapy. So that would be one possible therapy to consider, although that's kind of anecdotal. All right, so that's testicular hydrocele, and then spermatocele can also cause a painless scrotal mass, and that's a fluid-filled retention cyst in the rete testis, and that's at the head, either the rete testis of the testes or the head of the epididymis, so spermatocele down here. It may contain dead sperm. It feels like a smooth, firm lump in the scrotum on the top of the testicle, and it's benign. It doesn't affect fertility, and there's no increased risk for cancer. So that's where we just have to reassure our patients of that. So on assessment with a scrotal exam, we're going to feel a cystic mass at the head of the epididymis. It is going to transilluminate, and it's clearly differentiated from the testicle. So that's a very important point. When we feel the testes, we want to make sure they feel smooth, there are no nodules on them. This is going to be again, in the epididymis specifically, it's going to be slightly offset from the testis itself. If we're uncertain about this, just send for an ultrasound, and that can help differentiate it. Usually, no treatment is needed, but there is a spermatoselectomy that can be done to aspirate that and drain that if necessary. All right, so these are 3 very important causes of painless enlargement in the scrotum to be familiar with. 2 very important causes of painful scrotal swelling would be epididymitis and orchitis. And both of these are going to be caused by infections, most typically STIs. So epididymitis is inflammation of the epididymis, and that's usually from STIs, gonorrhea or chlamydia, prostatitis or reflux. So typically it affects males over 30, and we're going to see epididymal tenderness, tender and large testes potentially, fever, pyuria, presence of pus and or white blood cells in the urine, and pain is often decreased with scrotal elevation. So the testes hanging down, the scrotum hanging down, puts more pressure on the epididymis, and that can exacerbate the pain. The assessment's done through scrotal exam, palpation, so again it's going to be painful. An ultrasound Doppler might see increased blood flow to the testis. Urinalysis would again reveal pyuria, and then a urine culture, we could do that for GC or chlamydia or E. coli would be positive. And this is typically treated with both NSAIDs and antibiotics. Ceftriaxone and doxycycline are the most common combinations for epididymitis, and that's what we use to treat GC chlamydia. The complications would be infertility and chronic pain that results from that. So that's epididymitis. Orchitis would be inflammation of the testes. And this is less common than epididymitis, but the symptoms are similar to testicular torsion, which we talked about in the anatomy and physiology video, so I won't go over that here. We might see hematospermia, hematuria, severe pain, testicular swelling, and again, it can occur with actually epididymitis if it's from the same cause, like an STI, and we call that orchiepididymitis. So that would be a combination. Again, the causes, STIs, chlamydia, gonorrhea, mumps. We see this less now with immunizations, but previously when adolescent boys would get mumps, they would also develop orchitis commonly from that. It can also have ischemic causes, and that's damage from trauma to the spermatic cord. Assessment is going to be, again, scrotal exam, urinalysis with culture and sensitivity, and a Doppler ultrasound. And the treatment will be typically, if there's an infection, antibiotics, again, cephalexin or ciprofloxacin or doxycycline, and then NSAIDs would be the typical thing there. So very similar to epididymitis. And then testicular torsion would be another cause of painful scrotal swelling or scrotal pain. And I covered that in the anatomy and physiology section. In terms of disorders of the penis and urethra, we can have a couple of problems. So one would be congenital anomalies of the urethral opening. These happen in every 1 in 300 male infants. The first would be hypospadias, and that's the urethra opening that occurs on the underside of the penis. So instead of in the glands, here we have a penile opening on the underside here of the shaft, and that's called hypospadias, versus epispadias is the urethra opening on the top side. Now, if they're mild, there's different stages of this, then nothing needs to be done necessarily. But if it's more severe, that can really cause difficulties with urination. That might cause infertility because the sperm, when ejected, are not coming out appropriately. So this would require a surgical repair, usually in early life. So that's epispadias and hypospadias. Phimosis is the inability to retract the foreskin over the glands. And there can be different types where the whole glands remains covered in phimosis, or the foreskin kind of pinches around the shaft of the penis, causing paraphimosis. And this can promote poor hygiene there, infection, inflammation, scarring. It might encourage the development even of squamous cell carcinoma. So we usually need to treat this. Physiologic phimosis is common in males under 10. It's normal and usually doesn't need to be treated. It resolves with time. But the treatment usually is either non-surgical or surgical options. The most common non-surgical would be topical steroids. They tend to loosen the skin, and that would be either cortisone itself or betamethasone, and that would be applied, and then the foreskin would be stretched. I've used that with a couple of patients, younger patients, that was quite effective after usually a couple of months. If that isn't effective, then usually circumcision is recommended surgically. So that's phimosis. Balanitis is inflammation of the glans penis. It's less common in less common in circumcised males. We think the foreskin can actually potentially trap different bacteria and infective agents underneath the foreskin that might lead to increased incidence of balanitis. There's a lot of causes. Typically, though, it's from infection, STIs, GC chlamydia, could be viral, could be also fungal, candidal. Trauma, and then different irritants can cause balanitis. The treatment here is to kind of treat the relevant infections or causes and usually maintain proper hygiene. So with STIs, we might use the combination of the Cipro, the doxycycline, etc. And then with Peyronie's disease, this is a connective tissue disorder. This affects between 5 and 10% of men and becomes more common with age. And we see scar tissue that forms in the corpus cavernosum. And so this causes an abnormal penile curvature and can cause erectile dysfunction and shortening the penis. So it almost looks like the penis is bent. It's not from a fracture. You can have actually a penile fracture, which is where the corpora cavernosa actually, due to trauma, break open. But this is from scar tissue and connective tissue being deposited there. Without treatment, about 10 to 13% will improve over time. However, up to 50% will get worse, and the rest will sort of be stable. In terms of treatments, medication, there are different injections. Vitamin E, CoQ10 have all been used. There's a surgery called the Nesbitt operation, which is kind of a last resort. It can also install a penile prosthesis to straighten the penis. So that's Peyronie's disease. Priapism is a painful, persistent erection in the absence of sexual desire. And the erections last more than 6 hours. Some sources say 4, but usually by 6 hours we need to send the patient to the ED. There can be several causes, so infection, prostatitis or cystitis, sickle cell crisis, and then different medications and drugs can cause it. So this would be using, for example, the PDE5 inhibitors for erectile dysfunction. You get an erection that goes way beyond 4 hours. There's 3 types. Ischemic is the most common. It's also the most critical. There's non-ischemic and recurrent. For the ischemic, usually causes a painful erection, and that can eventually cause gangrene. So we consider this a medical emergency. And what they usually do in the ED for the ischemic, is to actually aspirate blood out of the penis. Not a comfortable procedure. And then to inject phenylephrine in the corpora cavernosum, and that is going to stimulate the sympathetic nervous system that blocks the parasympathetics, and that should hopefully improve drainage of the blood flow from the penis. And then surgical decompression can be done as well. So that is priapism. And then finally, I just want to say with cancers of the penis, these are uncommon, but they're typically squamous cell carcinomas, and they typically occur under the foreskin in uncircumcised males over the age of 40. And they're usually associated with poor hygiene and with increased HPV, human papillomavirus. So with penile cancers, it's typically squamous cell carcinoma. So that's a quick overview of the major disorders of the penis you should be familiar with. Finally, I want to say a word about testicular cancer. Most testicular cancers are malignant. They're the most common cause of painless enlargement in the testes. So that's why we're always with our general exams, especially in younger patients where a lot of these show up. We want to be clear to be able to palpate the testes and make sure there's no abnormality. These are testicular masses that will not transilluminate, and whenever we see that, we need to consider cancer. And testicular cancer most commonly occurs between the ages of 15 and 40. So unlike other cancers that happen in later life, these happen in younger life. So the most common are germ cell tumors, that's over 95%. Nearly all are malignant, and they most commonly occur in younger men. Their risk factors would be things like cryptorchidism, Klinefelter syndrome. Seminoma is the most common testicular malignancy overall. It's painless. We see a homogeneous testicular enlargement, so it's not lumpy or anything. It enlarges equally. It's most common in the 20s, never in infancy. And the histology of the testes reveals large cells. They're with a watery cytoplasm. We say they have a fried egg appearance. They're slow growing, late metastasis, and they respond very well to therapy. Usually that's surgery to remove that testis and the potential radiation therapy to address any spread to the lymph nodes from that. And the prognosis for seminomas is usually excellent if detected early. Yolk sac tumors, these are comprised of primitive endodermal cells. There's the most common testicular malignancy in boys under 3. Very aggressive though, and has very early metastasis to the lymph nodes, lung, liver, brain, and there's increases of alpha fetoprotein can be used as a diagnostic marker for that. Choriocarcinoma, this is composed of embryonic placental cells. Very malignant, goes to the lungs and the brain, can induce hemorrhagic stroke. And here there's an increase in HCG. Remember, this is a placental hormone. HCG acts like FSH, LH, and TSH, so it can stimulate all those receptors, and so it can induce hyperthyroidism symptoms, and can also cause gynecomastia. Teratoma, this is benign in children, but usually malignant in adults. Again, high HCG and alpha fetoprotein. And then embryonal carcinomas, and this is a mixed embryonal tissue. It's a hemorrhagic mass with necrosis, is painful. Worse prognosis than a seminoma, and again we have elevations of these tumor markers. Again, all of this will be if you feel an abnormal testicular mass, just refer for ultrasound, and we can from that determine whether or not a testicular biopsy is indicated, and to go from there. If you're again uncomfortable with any of that, if you're not a PCP, I'd definitely refer out to someone that can manage that. Non-germ cell tumors are the least common testicular cancer. Nearly all are benign, fortunately. So latex cell tumors, these arise from latex cells. They usually overproduce androgens, and that might cause precocious puberty in boys. Sertoli cell tumors arise from Sertoli cells. Typically, it doesn't cause elevated estrogens, but it might affect fertility, spermatogenesis. And then lastly, we have testicular lymphoma. It's the most common testicular cancer in older men. It's not a primary cancer. This arises from a metastatic lymphoma. It's very aggressive with a very poor prognosis. All right, so that summarizes it for testicular cancers, and that summarizes it for the major pathologies of the male reproductive system.